Hello, and thank you for joining us. My name is Rob Roth, Vice Chair of the PKD Foundation Board of Directors. Like many of you, my family has a long history of living with PKD, and that's why I've been a supporter of the PKD Foundation for many years. My grandmother and mother both died prematurely from PKD, and my brother and I are both recipients of successful kidney transplants as a result of having PKD. As a parent of two children, I'm especially interested to hear from our distinguished panelists on the topic of this first session. So we're thrilled to kick off PKDCON with an exciting discussion about genetic testing. We'll be hearing from two experts in the field of PKD, Dr. Dallas Reed and Dr. Lama Noradine. Dr. Lama Noradine is an associate professor of medicine in the Division of Nephrology and director of home dialysis at the University of Iowa. She also developed the university's first specialized PKD clinic. Dr. Noradine collaborates with a renal pharmacist, the Renal Genetics Clinic, and the Iowa Institute of Human Genetics, where patients receive comprehensive genetic testing and customized care. Her research interests include enrolling patients in multi-center clinical trials in AD-PKD, glomerulopathies, and rare diseases such as calciphylaxis. Dr. Dallas Reed is a double-boarded obstetrician, gynecologist, and medical geneticist with a passion for equity and inclusion, telemedicine, genetics education, and providing sensitive and culturally competent care to women and families during pregnancy and when confronted with uncertainty around a genetic diagnosis. Dr. Reed is an assistant professor in OB/GYN at Tufts University School of Medicine, the division chief of genetics in the Department of Pediatrics at Tufts Children's Hospital, director of perinatal genetics, and attending physician in the Department of OB/GYN at Tufts Medical Center. In addition, she conducts research around genomic sequencing in stillbirth and seriously ill newborns with possible genetic disorders. And here to add the patient and caregiver perspective based on their experience with genetic testing are Tam Steeden and Ann Wiseman. Panel, I'll turn things over to you.
Thank you, Rob. I'd like to thank the PKD Foundation for having me. Today, I will be discussing genetic testing in PKD, the benefits and the challenges. Just a brief overview, everybody in this panel and our audience probably is aware that AD-PKD is an autosomal dominant disease, which is monogenic, monogenic meaning that you only need a mutation in one gene to manifest the disease. And autosomal dominant means that it presents across multiple generations. The prevalence of AD-PKD is 1 in 1,000, and AD-PKD represents about 10% of end-stage kidney disease worldwide. PKD is caused by a genetic mutation in either PKD1 in 80% of patients and in PKD2 in almost 20% of patients. And recently, they've coined a PKD3 called the GANAB gene mutation in about 0.3% of patients. Now, as we all know, polycystic kidney disease clinically manifests as very large kidneys and made up of multiple cysts on both sides. Patients have a family history of kidney disease and renal failure. Some patients may develop liver cysts, and some patients may have a personal or family history of cerebral aneurysms. The diagnosis is usually made by ultrasounds for classic PKD, except in GANAB. In GANAB, this is mainly a disease of the liver, where, as you can see here on this two-panel MRI scan, you can see in patient A, large gray circles representing liver cysts in the asterisks, and very small cysts in the kidney, unlike classic PKD. Panel B represents another patient with a GANAB mutation with less severe disease. You can see these white, moderate-size cysts in the liver and two large cysts, one in each kidney. We all know that the ultrasound-based modified Ravine's criteria for diagnosis of PKD, presented here in the graph, patients with a positive family history who are less than 30 years of age must have at least two kidneys in one or both, at least two cysts rather, in one or both kidneys. But as you get older, when you are between age 30 and 59, you must have at least 4 cysts, 2 of which are in each kidney. And after the age of 60, you must have a total of 6 cysts to make the diagnosis, at least 3 in each kidney. But if you have a negative family history, you need at least 5 cysts to make the diagnosis prior to age 60. And the number of cysts goes up to 8 after age 60. Now, MRI is even more sensitive than ultrasound. And by sensitive, I mean how much does the modality of testing like ultrasound or MRI correctly identify all patients. On MRI, if you have a first-degree relative with PKD and you are above age 16, you need greater than 5 cysts to make the diagnosis. I do want to bring up 2 important hypotheses to understand the mechanism of disease. And why I bring this up is that it's quite important to understand the implications among family members with the same mutation and why certain family members present differently in such a various pattern. Some patients within the same family may have very severe disease and others not so severe disease, although they all have the same gene mutation. The first hypothesis is called the 2-hit hypothesis. And in this hypothesis, basically, PKD patients inherit the first PKD mutation in a germline fashion. So it's a germline mutation. And germline cells are those cells that pass on genetic material to their offspring. And at some point later in life, they may develop an acquired PKD mutation in a somatic fashion through somatic cells, which are cells that all the other cells in the body that do not pass on genetic information to offspring. So in PKD, you actually need 2 hits, both of these hits, in order for cysts to grow. And this becomes quite important, again, to understand why some people get disease really early in their life and others not so early. The second hypothesis is called the gene dosage hypothesis. And in this hypothesis, you basically have to have a critical normal threshold of functional polycystin 1. Polycystin 1 is the protein coded for by PKD1. Polycystin 2 is the protein coded for by PKD2. So you need a minimum amount of functional polycystin 1 protein to prevent cyst growth. So you can see how as you lower the levels of polycystin 1, more significant cysts grow, and this will lead to more disease burden. So in the grand scheme of things, although autosomal dominant polycystic kidney disease is a dominant disease across generations, at the molecular level, you can understand how sometimes it presents in a recessive fashion. This is a cartoon representation and a picture of what I just described. So whether you develop PKD is a manifestation of how much healthy polycystin 1 protein you have. So in this normal healthy individual with normal kidneys and no cysts, you have both PKD1 alleles intact and 100% of the polycystin 1 protein is functional. And if you inherit one inactivating allele here, you will develop adult onset PKD such that only 50% of polycystin 1 is functional. If you have both alleles are affected in PKD1, this is not sustainable with life, and it is embryonically lethal because 0% of PC1 is functional. But I'd also like to bring about highlight another important point, is that some patients may develop what we call hypomorphic alleles. And by hypomorphic, I mean variable penetrance. What this really means is that despite carrying a gene mutation, you may not manifest the disease. So for example, this patient here with a PKD1 R3277C allele with the second allele being normal may only present with only few cysts because 75% or more of their PC1 is functional. But if you develop this in a hypomorphic allele in both alleles, if you basically inherit both alleles, you will develop adult onset PKD. And if you develop one allele with the second allele being missing, you will have a more severe disease in utero after as soon as the embryo is viable. So there are also modifying factors, meaning that if you have other germline and somatic mutations in other loci of other genes, this may also affect disease burden. And there are also environmental factors. So if you eat a lot of salt or don't drink enough water, you may also have a higher burden of disease compared to other family members. So what are the challenges of genetic testing in PKD? There are 3 main challenges I'd like to highlight. The first challenge is that the proximal portion of the PKD1 gene has a duplicated region due to the presence of 6 pseudogenes. This makes genetic sequencing and testing somewhat of a challenge. Another point is that all of us in our genome have something called copy number variants. What these are duplications, insertions, or deletions of large portions of DNA. And these may sometimes these are fairly common and they may sometimes cause disease, such as in PKD. A third important point regarding challenges in genetic testing is that some patients may have what we call phenocopies. What that means is that they may have cysts in their kidneys that are not due to PKD1 or PKD2 or GANAB, but may look like ADPKD. An example of this is the HNF1 beta mutation, where patients have renal cysts and diabetes at an early age, and they may also have congenital anomalies of the kidney and urinary tract, as represented here by this bicornuate uterus or a heart-shaped uterus. Patients may also have horse-shaped kidneys or duplex ureters, among other anomalies. And here I'd like to highlight this MRI scan where patient A has more significant cystic disease than patient B, as represented by these white round circles, which represent kidney cysts. So what are the methods of genetic testing? Genetic testing usually is performed through next generation sequencing. It is an inexpensive, rapid, and well-utilized method to do genetic testing and pick up PKD1 or PKD2 mutations. It's basically performed against a target gene panel. You may test for PKHD1 gene that is responsible for the ARPKD disease, or HNF1 beta, responsible, like I said, for renal cysts and diabetes. The only caveat is that this technique may not be the best way to pick up larger deletions. So picking up larger deletions and copy number variants I just described, you may need to use other technologies listed here in order to perform the genetic sequencing and obtain the correct variant or mutation. Once you get the report, you will find that it is either a positive or a negative or a variant of uncertain significance. My colleague, Dr. Reed, will describe that a little bit more. But when you are not sure that the variant or mutation is of clinical significance, meaning you don't know if this manifests as a pathogenicity or as disease, sometimes we end up having to do clinical correlation and segregation analysis. And that just means we gather more data from family members and even end up genotyping siblings and parents in order to find out if this is truly the cause of disease. Now, there are many risk factors for disease burden in PKD. Some of these are acquired. For example, having hypertension makes you at risk of a higher burden of kidney disease, or being of the male gender, or having urological symptoms like frank blood in the urine or hematuria or flank pain or kidney stones. And like I highlighted earlier, there are genetic risk factors, like having an early familial history of renal failure, which probably means you have a more severe PKD mutation, or even inheriting another cystic gene mutation that may amplify, the cyst disease and may make it more severe, such as an HNF1 beta mutation. Or having, for example, a tuberous sclerosis PKD contiguous gene syndrome, where you have a deletion in TSC2 and PKD1. So these two are not to be confused with acquired cystic disease. In acquired cystic disease, we all, with time and age, have kidneys that shrink, become smaller, and develop cysts, and these are not genetic in nature. So when to seek genetic testing? I think this is the most important slide of my brief presentation here. If you have a negative family history, and this occurs in about 10% of PKD patients. If you are without a known mutation, and this also occurs in about 10% of PKD patients, they don't always have a known mutation. If you have early and severe ADPKD, or if there's a discordant disease within family members, one patient develops or manifests very differently than their uncle or their parents. If you're interested in knowing what your prognosis may be, you want to do genetic testing. Or if you want to screen your children or your siblings. Or if you are at high risk for brain aneurysms. For example, divers or pilots, have a lot of pressure that they have to undergo, and they may be at risk of brain rupture or brain aneurysms and aneurysm rupture, rather. If you are interested in being a living kidney donor and you have a family history of ADPKD, you may want to seek genetic testing. If diagnosis is in doubt or atypical presentation, for example, what I described in GANAB, where you have very small kidneys and almost normal looking kidneys, but only have liver cysts, or if you have asymmetric kidney size, meaning one kidney is a lot larger than the other, or if you want to be treated with tolvaptan, the only FDA approved drug for treatment of ADPKD, and you want to consider whether you are at high risk of progressing your kidney failure and whether you qualify for the drug. Or if you're interested in family planning and you want to undergo prenatal genetic diagnosis. So there are hundreds of tests out there, commercial tests and different platforms in order to sequence PKD1 and PKD2 or test for PKD. I would like to highlight one comprehensive renal genetic test that we have at our institution. And the reason to highlight this is purely academic and educational. I do not have any stocks in this company. I have not participated in formulation of this whatsoever. So KidneySeq is the platform that we use at the Iowa Institute of Human Genetics. And what's interesting about this is in one lavender top test tube, we can test for 312 genes, all kidney specific, 85 of which may be related to cystic diseases or ciliopathies or mutations in cilia, or tubular interstitial diseases, which is basically kidney fibrosis. An example of that is autosomal dominant tubular interstitial kidney disease, or ADTKD. 56 of these genes can test for congenital anomalies of the kidney and urinary tract, I discussed briefly. I usually send all my patients to the renal genetics counselor first, so that patients really understand the implications of genetic testing and whether they really want to go through it. The genetics counselor can help obtain prior authorization to cover the cost. We usually do a good job and manage to get this approved. The out-of-pocket cost is not too bad. It's about $2,000, which is very comparable to other platforms. And the results are interpreted in detail by a multidisciplinary team of physicians, geneticists, genetic counselors, bioinformaticians, and scientists. And the variants are interpreted in great detail and checked against public databases, such that new variants can be reported as well. This is an example of a KidneySeq panel result of a patient that I requested genetic testing on. She presented to me, and she's in her 30s and has a pretty typical ADPKD by phenotype. And interestingly, she has a likely pathogenic variant in PKD1, but she was also found to have a variant of unknown significance in the PKHD1 gene, which basically is responsible for ARPKD. So that's quite interesting. I also want to highlight one more important point that genetic screening can be used for the purpose of prognostication or finding out what your prognosis is. For example, the PRO-PKD score can predict end-stage renal disease or developing kidney failure and going on dialysis before the age of 60. And this can be done by adding up points from 0 to 9 using multiple variables where each variable is assigned a point. For example, being of the male gender provides you with 1 point. Being hypertensive before age 35 is 2 points. The first urological event before age 35 gives you 2 points. And then there are points assigned according to what PKD mutation you have. So if you have PKD2 mutation, which is the mildest form of PKD, where patients don't develop kidney failure until later in life, that gives you 0 points. Whereas if you have a non-truncating PKD mutation, which means that part of the protein still exists and is still functional with functional polycystin 1, that gives you 2 points. But if you have truncating PKD mutation, which is the most severe form where the protein is actually truncated or shortened and absent, that will give you 4 points. So I'd like to bring your attention here to this Kaplan-Meier curve where the age is presented here on the x-axis and the y is represents the probability of survival in end-stage renal disease. So if you're a 1, that means here you do not go on to develop end-stage renal disease and dialysis. And if you're at 0, you are more likely to require dialysis. And this just shows you that PKD1 truncating mutations are much more severe, where on average, the patients will present into renal failure in their mid-50s compared to PKD2, where that may not happen until 75, and about 50% of patients in PKD2 may never develop renal failure. So the scoring system 0 to 9, in this Kaplan-Meier curve, you can see that if you are at low risk and you have points between 0 and 3, the median age of end-stage renal disease onset is about 70. Whereas if you're intermediate risk here in blue, the median age of onset of end-stage renal disease is 56 or 57. And if you're at high risk, you develop end-stage renal disease quite earlier at age 49. Lastly, you can use genotyping with the MRI to measure the total kidney volume. So you can basically complement the Mayo Clinic ADPKD imaging classification with genotyping in order to evaluate your risk of progression to end-stage renal disease. So in the Mayo Clinic classification, it goes from 1A to 1E, where a height-adjusted total kidney volume that is larger, such as in 1E patients here in turquoise, predict the worst outcome. And these patients go on to develop end-stage renal disease in their mid-40s, compared to 1A, where they may never go on to develop end-stage renal disease or may develop this very late on in life. And if you combine both genotyping and the Mayo Clinic score, you will be able to prognosticate your risk of developing ESRD or dialysis. And I'd like to end with this beautiful editorial called The Patient's Voice, written by Dwight Odland, our Los Angeles PKD Foundation chapter coordinator, a patient perspective on genetic testing for ADPKD, where he highlights the pros and the cons. Some of the pros he highlights are, I wish I had known. I could have, intervened earlier, or had a healthier lifestyle, or increased in water intake, or paid more attention to blood pressure, or had the chance for family planning, or advanced living donation. This is where parents can donate their kidneys to their kids who have yet to develop end-stage renal disease in exchange for a voucher that can be used and passed on to the child later on in life. Some of the cons, however, of genetic testing he highlights are, now you're stuck with a pre-existing condition. You may have difficulty obtaining insurance or high premiums, and some patients are not emotionally ready to hear this news about having a genetic disorder. In summary, the cost of genetic testing is $2,000 to $3,000 on average for most platforms. It may be covered by insurance. It is accessible and complements other imaging like MRI scans and others that are much more costly. And I believe that incorporating genetic testing into practice really may improve the diagnosis, the ability to prognosticate and select patients who benefit from treatment. Lastly, a plug-in to the PKD Foundation. They have a registry where they collect data on access to healthcare and genetic testing. So if you're a patient with PKD, feel free to sign up to this registry, as we are powerful in numbers. This is my contact information if you are interested in reaching out to me personally for questions or concerns, or using this platform. I'm happy to answer questions. I'd like to introduce now Ann Wiseman. Ann is a mother of two wonderful young men, Ethan, age 13, and Logan, age 11. Logan was diagnosed with ARPKD at the age of 2. She has been an active member of the PKD Foundation for the last 9 years, helping in various roles. And Logan received a kidney transplant 4 years ago, and he donated his kidneys to research. Her family wrote 2 children's books, Logan's Bumpy Kidneys and Logan's New Kidney, to help families explain PKD and transplant to young kiddos. The PKD conference has been a huge asset to her family as they've navigated this disease, and she has made many lifelong friends through the connections formed at this event. Take it away, Ann.
Thank you so much, Lama, for the introduction. Hello, fellow PKD warriors. I know this time we're virtual, but hopefully next conference we get to be in person again, and I can get my hugs. As Lama's indicated from my brief bio, my Loganator is 11. He was diagnosed with ARPKD at 2 years old. We were fortunate enough to have a living donor transplant 4 years ago. But it wasn't until the PKD Connect event the year after his transplant, and I will say every time I come to this conference, my ears hear different new data that they don't hear the time before. So I think this is my 5th one of these, and every time I learn something new, including today, just now. But I learned that the ARPKD kidney looks very different than the ADPKD kidney. And as, again, my bio stated, Logan got to donate both of his kidneys to 2 different research facilities. And if you get the opportunity to do such a thing, all of us PKD warriors benefit from that. And his kidneys did not look like ARPKD. So we had been operating for 6 years thinking ARPKD, 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 and it wasn't meshing anymore. So we are like, oh my goodness, now we don't have answers. I don't know how to, like, what's his diagnosis? I need to know. I'm one of those people, I need to know. So we're like, we should do genetic testing. Let's do this. I need an answer. We need to figure this out. So we got the genetic tests, and just like everything with PKD, everybody's story is a little bit different, but Logan is special. And Logan has markers for both AR-PKD, AD-PKD, and this random third marker that at the time, which was, again, a couple years ago now, at the time, I was informed that not a lot of research was being done on that specific marker. So I was left with no answers. So I'm what do I do now? Like, how do we operate? So then we started looking at other symptoms. We are like, well, maybe something else that's happening will give us guidance, right? Because the additional symptoms for AR PKD look different than the ones for AD PKD. But now that he has both markers, like his annual ultrasound, we're not only looking for like CHF, right, which is common for AR PKD, we're looking for cysts all over his abdomen to try and find anything else that might indicate maybe it's more of the AD PKD diagnosis. So I'm happy to say he has neither. So he doesn't have CHF. He's been diagnosed with the disease for 9 years. He had an insanely aggressive PKD for in his kidneys, but it's not showing anywhere else. So we feel kind of, I mean, I feel like lucky on some level, as lucky as us PKD warriors get, but a part of me was just like, well, maybe it's okay that we don't know. Can I be okay not knowing? And he's doing great. He is doing absolutely wonderful. Transplant kidney is still functioning decently well. So we're allowing ourselves to be okay. We're gonna we got through some pretty tough times, and we're gonna allow ourselves that, right now there's nothing critical that's telling us we need to do this. So I'm hoping in like the 15 to 20 years when maybe he'll start family planning, we can come back to this genetic conversation and we can start to figure out, okay, what are his options for family planning? Because when I think about like all of the wonderful research that the PKD Foundation funds and insanely smart people like Lama and Dr. Reed, who's going to get to speak next, all of the wonderful work that they do, it gives my child the ability to not see their kiddo go through what I had to see my kiddo go through. And I can't thank those geneticists enough, and I can't thank the PKD Foundation enough to create those type of opportunities for my kid. So while we don't have the family history, the thought that it could start and end with Logan is just an incredible piece of hope, I guess, to hold on to. So I just want to say thank you for all of the work that the professionals, especially the ones who are coming here to explain their work to us, do for us so that we have those type of opportunities. So thank you.
Thank you, Anne. I think you speak to the work that we do in genetics all of the time. So I'll go through a little bit about what we do as geneticists and genetic counselors, but you are perfect in explaining sort of all of the hard things that need to be thought about when patients consider genetic testing, and we'll get into a little bit of that here. So I'm very grateful to be here presenting a little bit about what genetics role is when we're talking about PKD and other kidney conditions. What wasn't in my bio is that I have family members also with PKD. And so it's not just a professional connection, but a personal connection with this condition. And so hearing from patients and families like you, Anne, is really, really helpful. We can go to the next slide. So I wanted to start. Dr. Noradine, I think it gave a great overview of sort of all the things that we think about with PKD, what's happening with the biology of the kidneys, what's happening on the genetic side, and I'll touch a little bit on some of the things she talked about. But always my first question for patients or from patients or other professionals actually is, well, what is your job? What do you do? So I'm a geneticist, which is a physician. Also, sometimes we're called medical geneticists or clinical geneticists. And we have MD degrees or DO degrees, so have gone to medical school, completed 4 years of that. And typically, to be a geneticist, you have to do a residency program program or a training program in some specialty before you actually do your genetics training. So my training was in OBGYN, as was discussed during my bio. And after my 4 years of OBGYN training, I did 2 years of a genetics training. In genetics, we learn about a broad array of conditions, ones that affect fetuses, children, adults, and people that are elderly. We focus a lot on conditions that affect the different organs, how they form, as well as intellectual disability and cancer in particular. People who are geneticists may work in the clinical setting like I do, where I see patients all day. Sometimes people work in research settings, trying to develop these genetic tests or develop the treatments that are targeted towards different genetic mutations or genetic conditions. People may also work in teaching settings. I do that as well. I work at our medical school here at Tufts. One point I wanted to make is, one of the reasons why it's really important to have collaborations between genetics professionals and other types of physicians or specialties is because it's really hard to find geneticists. In 2019, there were only 1,240 geneticists in the United States. I looked up how that compares to other specialties, and I looked up nephrologists because Dr. Noradine is a nephrologist, and there's about 8,000 nephrologists in the US in 2019. And that includes children and adult nephrologists. I think it was 8,500. So it's very, geneticists are not everywhere. And so that's why it's important we sort of have these broader conversations where the two specialties are discussing things with each other, because it's hard to get somebody in every hospital and every place that patients may be seeing people. We can go to the next slide. And then genetic counselors are different types of healthcare professionals. So they typically work with a genetics physician, or as Dr. Noradine said, they have a renal genetic counselor that works with their clinic. And these are people who have completed a 2-year master's program. So they haven't done any medical school, but in their master's program, they do learn a little bit about some of the basic things. Sometimes they take classes with medical students in anatomy and other topics. And really their specialty is integrating the genetic knowledge with these counseling skills. And so when Anne was speaking, I think it was speaking to a lot of the things that we deal with in these encounters, and the genetic counselors have their expertise in, which is talking families through the emotional parts of what it means to make a diagnosis, what it means to have a diagnosis, and what this means for the future for that family, because it's very emotional, as you could tell by Anne's story. Genetic counselors often work very much in parallel with geneticists, so they may work in clinical settings like I do. I have several genetic counselors that work with me. They may work in industry, either developing studies or developing genetic tests. They may work in a teaching setting or do a little bit of a combination of both. And really, they excel at collaborating with physicians, non-geneticists and geneticists, and talking about the complex concepts that come with genetics. As Dr. Noradine presented, it's very complicated, and make sure that it's understandable to patients and that they can bring their values to those conversations and know sort of how to proceed based on those values. And as a comparison, in 2019, there was about 4,700 genetic counselors. So about 4 times more than there are geneticists, but still, half the number of nephrologists, for example. So it is still a group of people that is very sparse. And, another reason why we need to collaborate more and more. Next slide, please. So I just wanted to talk a little bit about what genetic counseling is and why it's really important. And if it is at all possible for someone to see a genetic counselor before they make decisions about genetic testing, I would very, very much recommend it. There's sort of 2 parts to the genetic counseling world. The first part is pre-test counseling. And these are some of the elements of what happens in those encounters. First is there's a very, very detailed medical and family history that's taken. And we often draw, those of you that have seen a genetic counselor or geneticist, we often draw a family tree, which is called a pedigree. And we're sort of drawing where everyone is in the family, how they're related to each other. what diagnoses they may have. If they've had genetic testing, what are those results? What features of the condition do they have? So do they have cysts? Was there one cyst found one time on an ultrasound? The advantage of going to genetics to do this type of evaluation is that, it speaks to some of the atypical types of kidney disease that Dr. Noradine was talking about, in the sense that we can look and ask questions about other things. We're not thinking just about the kidneys. We're thinking about all the different things that could happen for a patient. And so we're often asking those questions and looking for patterns. So although PKD may have a particular picture, I think Anne spoke to sort of the complications when somebody may or may not actually clearly fit a particular diagnosis. And it's our job to sort of dig in more to the personal and family history to figure out if there's other clues as to what could be going on. And those clues are very important in us determining what genetic test should be ordered or what condition we think might be going on. So after getting that family history, we actually can look at that and assess and say, what is the risk for this individual that's seeing me? What is their risk for their children, depending on what we think the diagnosis may be? There's a lot of emphasis in this pre-test counseling session about education. So if we have, if a patient comes to us with a clinical diagnosis of PKD or a suspected clinical diagnosis, we can talk more about that condition. I'm sure they've heard a lot of it from their nephrologist or their nephrology team, but we talk about it again and we go over what the features are, what the percent chance of having the features are, if that's known, what other things, other parts of the body could be affected, what other phenocopies there could be, so what other conditions look like this particular condition. And then we can talk about if somebody was to be positive for this, what are some of the things that would change for them? What would we do for screening? Would there be anything we could do to prevent illness? Is there anything special about management? Is there special medications that are out there that could be targeted to the person's diagnosis? And then obviously, a very important part of that encounter is the genetic testing. So we have a detailed conversation about that, again, before we've even ordered the testing. We talk about what options are available. Dr. Noradine talked about one particular genetic test that's available at her institution and is available across the country, but there are many genetic tests that are very similar to that one. And it's very important to, especially if somebody's a little bit unfamiliar with the genetic testing, as far as a physician, for example, that they talk to a genetics team about what exactly to order, because we want to make sure that we're looking at the next generation sequencing and the deletion duplication analysis for one patient, so that we're not reassuring ourselves that if they just had one or the other, that we've actually ruled out the condition. And so that's where genetics can be very, very helpful, in that we know what all the labs are, what all tests are out there. And something that we spend a lot of time worrying about and making sure is clear is, how much is this test going to cost the patient? And we have those conversations at the beginning before we've even ordered anything. One of the points that Dr. Noradine brought up was about insurance and discrimination. And so I want to make a point about that. There is a law in place called GINA, Genetic Information Non-Discrimination Act. It was a law put in place by President Obama in 2008. And what that law does is it actually protects people who have a positive genetic test or a genetic diagnosis from losing their health insurance and their employment based on that diagnosis. So you can't actually get higher premiums for your health insurance based on any type of genetic test results. What it does not protect you against is higher premiums or denial for insurance for life insurance, long-term care, or disability insurance. And so we have that conversation before we order the testing, because if a patient wants to pursue those things and get those in place before they have their genetic testing results back, we want them to have that opportunity. Next slide, please. And then after we actually do the testing, if the patient wants, I would say also part of that genetic testing is the informed consent process. What are we looking for? What are we not looking for? Talking about those insurance pieces and really getting into a detailed conversation about cost. After those results come back, there is a follow-up session, and this is to do what we call post-test counseling. So it kind of has a couple of different parts. One is, of course, actually, even before we see the patient for the results, is to interpret those results. So Anne brought up a great point that her child had a genetic test that had different markers that were there. And we'll talk on the next slide about these types of results you can get from genetic testing, but it often requires a geneticist or a genetic counselor or the two together, and oftentimes with other specialists like nephrologists, to really sit down and look at what are these results, how certain are we about them, what do we know about this particular gene? So especially if you're doing a big test like the one Dr. Noradine was talking about with over 300 genes, it's possible it may come back with lots of markers. And it's important for us to understand what are the features of all of those genes, how does our patient fit that picture, and how certain are we about those results. And so there's actually a effort made prior to even talking to the patient about the results to interpret them for ourselves, make sure we understand what they mean in the context of the patient's history. And then we actually talk to the patients about the results, explain what they mean. So don't just hand them the piece of paper and say, hey, you're positive or you're negative. We really go into the details of what we looked at, what we maybe didn't look at if there were some limitations there, and what these results mean exactly. And often provide letters that explain everything in layman's terms, so you're not trying to interpret the genetic mumbo jumbo that's on these reports, because they can be quite long. Most genetic reports are several pages long, and it just goes into sort of the nitty-gritty detail of the technologies that were used, which is important for someone like me. If we think a patient meets a particular criteria based on their presentation, but had a genetic test that was normal, I need to look at those nitty-gritty details and say, well, did they just do sequencing, or was it sequencing and deletion duplication analysis? Was there something that was missed? And we know that genetic testing technologies change over time. Anne spoke to the fact that maybe in 15 to 20 years, we can readdress this. I would say that's probably something that can be readdressed sooner, because the genetic knowledge is changing so quickly. And I hope for her family that that's something that can be readdressed sooner. But this is where that important information is, but that's important to me, not so much to my families. And then really where the genetic counselors shine is with this patient-centered counseling. So, our role is, of course, to see our patient and help diagnose what's going on with the patient. But our very, very secondary role, and the next thing we worry about, are the family members. So we can have a really important conversation about, now that we've dealt with what this means for you, what does this mean for your siblings, your parents, your children? Who are the other people that should see a genetics professional and consider doing genetic testing for this? What if they don't want to do genetic testing? What would we recommend that they do for their healthcare to make sure they are being watched in case they might develop the particular genetic condition that we've diagnosed? And then to what Dr. Noradine was talking about with family planning options, what are your options? What can you do to and Anne spoke to this too, what can you do to not pass this on to another generation in the family? Next slide, please. The last thing I just wanted to talk about was the interpretation of genetic tests. And Dr. Noradine touched on this and said I might mention it. We certainly know that there are different types of results we can get on genetic tests, and it ranges from this negative result, which means we looked at all the genes, the 315 genes like on the panel Dr. Noradine mentioned, and those were all normal, to the other side of the spectrum, which are the positive results where we say, yes, you have a change, it is related to disease. But there's this middle category that drives us all crazy, the patient's crazy, the doctor's crazy, which is this uncertain category. And when that comes up, it's very important really to have a genetics team involved for two reasons. One is that the genetics team can help determine how closely does this genetic change actually fit with the features we know about the patient or the family. And secondly, over time, we learn more about these uncertain changes, and the labs and the medical knowledge changes. And so if that uncertain change one day became a pathogenic change or a positive result, somebody needs to be able to communicate that to the family. And right now in genetics, there is no one that actually keeps track. There's no one that's charged with making sure the patient knows that information. So in my clinic, for example, we take it upon ourselves to keep track of the patients who have uncertain findings in any gene, and we follow up with labs on a regular basis to make sure that we've been updated if that changes. So, things change over time in genetics, and it's really, really important to stay connected with your genetics team or the genetic counselor so that they can continue to keep you up to date on the most, up-to-date knowledge about that particular change. Next slide. So this is my contact information. I'm hopeful that we'll have some time to answer some questions. But if you have questions for me, please feel free to reach out. And I will give another plug for the PKD Foundation. Actually, in the registry, I help make their the survey that goes out periodically. We've added some questions about family planning and children and all of those things. So I hope you take some time to look at that and give us your input. Thank you so much.
Hi, I'm Tom Snedden. I'd like to thank the organizers for the opportunity to tell my story. Full disclosure, I do actually work in the field of medical genetics, but I'm here today actually for the first time publicly as a patient with ADPKD. I was diagnosed in my late teens by ultrasound. It was not a surprise. I'd had episodes of hematuria and flank pain throughout my childhood. And more pertinent, my mom had been diagnosed 20 years previous with ADPKD. So fast forward 20 years, and my partner and I are in California. We both have good jobs at Stanford, good health insurance, which in this country is important. And we decide to start a family. I'd never really thought about the implications of passing on my presumed PKD mutation. But because of many reasons, including our age getting close to our 40s, we decided to go via IVF. And so thinking about the money and the time and effort put into that, it was sort of an afterthought as to whether we could or should test the embryos for whatever pathogenic variant I presumably carried. And as I say, this is sort of also my work is in genetic testing. So it was quite a dilemma and hard to wrap my head around what to do about that question. I mean, what did that say about my life? Having, I was almost 40. I'd had, the past 20 years, I'd done a lot of traveling, had some great advances in my career. I was a triathlete. Obviously, PKD had impacted my life, but in minor ways that I would certainly not choose to not have children because of it. How would I feel if somebody chose not to choose me as an embryo? Because I kind of like my life. So it was really hard. But we worked with the IVF clinic at Stanford, and we asked the question, is this a possibility? Because ultimately, I thought, could I live with the guilt if I knew I could stop passing this on and had the means financially and otherwise, but decided not to. And I realized that once I started going down that path, then I had to follow through. And it turned out that the company Natera, who I believe are presenting and present at this conference, they said they could do it, but obviously they'd need to know the familial variant. And surprisingly, I'd never had clinical genetic testing at this point. I've regularly seen a nephrologist. I'd been vegan for like 15 years. I thought I knew how to take care of my body, and I was pretty healthy. So I didn't think that knowing my variant would be useful to me in any way. However, for this purpose, it was. And so, as I say, we had good health insurance, and I appreciate that, there are a lot of genetic panels these days, and this happened some 6-7 years ago. But we pretty much knew that I had PKD1 or perhaps rarely PKD2. So at that point, Athena Diagnostics was covered by insurance, and we sent to them for sequencing of the PKD1 and PKD2 genes. And the results came back that I have a frame shifting or a truncating variant in PKD1. And so we worked with Natera. We went through two rounds of egg collection and two rounds of IVF, sorry. And then we pooled. So I think there's other talks about the sort of the technology behind this, but basically at the sort of the 5 or 6 day embryo stage, one of the cells is removed, sort of biopsied. Those embryos are frozen, and then the DNA, well, the biopsies are sent to Natera, and Natera extract the DNA and perform the assay. So Natera actually, from getting the clinical genetic report of the variant, which as Dr. Noradine mentioned, this was in the duplicated part of the gene, so it would be a somewhat complex assay, but their turnaround time in developing that was 6 weeks. And also at that time, they only worked with one insurance provider, which fortunately was the one that we had. It was Blue Cross Blue Shield of California. So they actually direct billed the insurance, and we didn't have to pay any of the bills for the work that Natera did. So we sent them 9 biopsies from the embryos that we got. And of course, you wait, and it's if anybody's gone through IVF, it's all the waiting and expenses are excruciating. But Natera returned the results in 5 days. And out of those 9 embryos, we had one that was chromosomally normal and did not carry the truncating variant in PKD1. So that in itself was also, great that we had one, which obviously we would try. But what if that failed? What if we wanted more children? We had two other embryos that were chromosomally normal, but were PKD positive. So we were in quite a dilemma, my partner and I, and we actually went through another round of IVF. We got more embryos, but it turned out that none of those were PKD negative either. So we were left with one embryo, and we implanted it. And to cut a long story short, our daughter, who is confirmed PKD negative, will be celebrating her 6th birthday in August. And I'm happy to talk to anybody who'd like to talk more about this experience offline or at other points during this conference. Thank you.
Thank you, panel. That was wonderful, very informative, I'm sure, for our whole audience. As a reminder, before we start the Q&A, please keep your microphones muted and type any questions you may have into the question box. So let's begin the Q&A with our first question. Genetic testing is sometimes covered by insurance and sometimes it isn't. Are there clinical reasons that genetic testing is covered, or is it always up to your specific insurance plan whether or not genetic testing gets covered or not?
Maybe I can take that one, since it's something we talk about all the time, every day in our office. The genetic test, the insurance companies usually have what they call medically necessary criteria for genetic testing. And so it very much depends on what those criteria are for your particular insurer. And oftentimes it requires looking into what those criteria are. We tend to use at our clinic, use labs that will do that investigation for us. So Dr. Noradine talked about that benefits investigation or that prior authorization process. That's what that process is to determine, does it meet the criteria for your insurer? Unfortunately, a lot of insurers do not cover the cost of PKD testing, especially ADPKD, because it can be diagnosed clinically. And their perspective is, well, you already know the diagnosis. Why do you need this information? And so it's a constant fight in genetics to say, well, there are lots of other reasons why. And Dr. Noradine, I think, outlined a lot of them, especially around family planning and treatment and prognosis and other reasons. It's a little bit easier if there's a history of kind of an uncertain picture with the kidneys. A lot of times we can get that covered. But I will say most bigger genetic testing laboratories, even if your insurance denies the testing, they have pretty favorable cash prices. This is where talking to genetics can be really helpful as well. So labs like Natera, for example, may have an out-of-pocket cost that's capped at $250 or $300, even though the test was not covered by your insurance. So it's definitely a place to bring in genetics to say, hey, can we talk about what's available, what's out there, and how much that may cost?
Okay, next question. Can commercially available genome sequencing be used to detect AD-PKD, or do the tests need to be doctor ordered and carried out at specialized facilities? This person's wondering if there's a way to keep test results out of children's medical records.
Also something that probably comes my way a lot. So when we commercially available to us means it can be ordered by a clinician and is not research testing. I think what you're asking about is direct to consumer genetic testing, and that's things like 23andMe, Ancestry, and the ones that are just, you know, you can buy on the internet and you don't need your doctor to write a prescription or order them for you. I don't want to speak to any particular company's direct to consumer test because we don't order those, but many times those results need to be validated. And so if you came to me as a patient with a report from 23andMe that had a particular result, I would do the same thing I do for every patient, which is get a comprehensive family history and make sure that I order genetic testing that's appropriate based on your family history. For certain genetic conditions, those tests have been wrong. And so I would not take that as the diagnosis without ordering something. So that does make it hard because once it's in the medical record, it's in the medical record, and we really can't keep it out of the medical record.
Do you recommend using genetic testing to diagnose or rule out an AD-PKD diagnosis in children that are at risk of PKD due to an affected parent?
I think that's important. I don't know if Dr. Noradine wants to speak on that. I think that is important because there are things that we would recommend for modification of their behavior, avoiding certain medications, looking out for certain things as they get older and bigger. But I'll let her comment on that, perhaps.
Yeah, I agree. I recommend genetic testing, but I also always discuss with the family members because oftentimes they don't want to know about their kids, and oftentimes the kids don't want to know, and they just psychiatrically cannot, emotionally cannot bear the burden of that diagnosis. So it's quite complicated. I do work closely with our renal genetics team, and I think Dr. Reed did an outstanding job, highlighting that in detail and the importance of. Another comment I want to make about the 23andMe, and I think they use, if correct me if I'm wrong, like smaller tests. They use single nucleotide polymorphisms, so they're looking for very small variants in the genome, and that's not enough for PKD 1 and 2. It may be for other diseases like sickle cell, but again, confirmatory testing. But in PKD specifically, I think that the direct to consumer rather, testing is not to be used.
Yeah, what they do is not exactly the same as what Dr. Noradine orders or what I order. It is not looking at the specific genetic changes. It's looking at like a pattern of genetic differences that are maybe near the place in the genome where that gene is. So it's a little bit complicated, but it's not the same.
Okay. When you have genetic testing done as a way to diagnose or rule out a PKD diagnosis, you also receive other genetic information, and if so, is genetic counseling recommended?
I think I've made my point clear on that. I think genetic counseling should always be recommended, really, for any genetic test, especially ones that are quite broad and not, super specific for the genetic condition that we're talking about. There are genetic panels, are what we call them, where they have a list of genes. So that's what Dr. Noradine presented, that one KidneySeq. That particular panel looks at all types of kidney disease, as she says. So not just cystic disease, but other types of disease. There are other big genetic tests like whole exome sequencing and whole genome sequencing that look at all of our genes. Those definitely need to have genetic counseling prior to ordering those tests because that's looking at all of the genes in the body. And there may be times that that's an appropriate test if somebody has a very confusing picture with their kidney disease and maybe some other stuff going on too. But that's where you can get into that place where you start to learn other things that you weren't expecting to learn. And we need to be talking about that before it's actually ordered.
Right. And an example of that, I'm sorry, is like Dr. Reed mentioned in the KidneySeq testing, we look, for example, for Wilms tumor. So, if you have a mutation in Wilms tumor, that would probably put you at risk for things like a gonadoblastoma, nephroblastoma. So that would have implications beyond PKD. It's very important to adequately counsel on that.
Right.
Okay, great. I see we're getting to the top of the hour. That's all the time we have for questions. Dr. Reed, Dr. Noradine, Tam, and Ann, any additional comments before we wrap up the session?
I would just say that, ask your doctor if they haven't offered you genetic testing and it's something you're interested in, ask them about it. Ask them if there's genetics doctors or teams that they work with. Even if you're not sure if you want to do it, having the conversation is what we're here to do. We're not here to make you get a test. And that might be helpful and informational.
That's great. Thank you, everyone, for joining.